Hi there, welcome back to my YouTube channel. Thank you so much for watching. Please remember to subscribe to the channel, click the notifications and like the videos here on YouTube. Also check out my playlist for the latest videos. Today I am speaking to Dr. Navid and he is a plastic surgeon in the UK. Hi there, thank you so much for joining me today. Please introduce yourself and just tell me a little bit about your clinic.
Hi Rana, my name is Navid Jallali. I'm a consultant plastic and reconstructive surgeon. I have a practice which is both NHS and private. My NHS practice is based in Imperial College and I'm on the Charing Cross campus where I essentially carry out breast, head and neck and skin cancer reconstruction. And I also run a cosmetic surgery practice in central London in and around Harley Street, where I carry out essentially cosmetic procedures of trunk and face. And one of my specialist areas is breast augmentation.
That's great. Okay. So today we're going to be talking about breast augmentation, like implants. So just tell me, who makes a good candidate for breast augmentation?
So generally the patients that we see for breast augmentation sort of fall into two categories. Ladies who are pre-pregnancy and generally have underdeveloped what we call hyperplastic breasts, versus the second group of patients that we see that are post-pregnancy that may have actually had reasonable breast volume, but as a result of the pregnancy, they find that the breasts tend to drop down or become ptotic, and they also tend to lose volume as a result of breastfeeding. And most of the patients that we see tend to sort of fall into an age bracket of somewhere between 18 to 40 years old. And those are the sort of most of the ladies that we see for breast augmentation in our practice.
Okay, that's great. So just tell me, when the clients have the breast augmentation, would they be having like a lift as well at the same time, or is that kind of two separate things altogether?
And that's a really, really good question. And so for most patients who are pre-pregnancy, it is extremely rare for a lift to be required. And in general, in those patients, I tend to advise against a lift if they're pre-pregnancy, because there is a small chance that they will not be able to breastfeed if they have an uplift done prior to falling pregnant and having children. And for ladies who are post-pregnancy, the breasts have often become ptotic or they're hanging, and so an uplift is required. In most patients, I try to do an uplift and an implant in one sitting, but in some patients where the skin envelope is not adequate or that the drop or the hang of the breast is too severe, we may have to stage the operation and do an uplift first. And once that heals, then carry out the augmentation at a second operation.
Okay, great. So just tell me, in your practice, what are the different types of implants that would be offered to clients?
So there's lots of things to consider about implants and the types to be used. The first thing to think about is about the shape of the implant, and they broadly fall into round implants versus the anatomical or pear-shaped or teardrop implants.
Okay.
When the teardrop implants were developed, everyone got very excited and we thought this is going to be the kind of the panacea to all the problems of breast augmentation. And so I used to use quite a lot of teardrop implants in my practice. But as time's gone on, we've actually realized that probably you can achieve very, very similar results to teardrops with round implants. And so in my practice, most of our implants are now round, and that has the added advantage that the implants tend to be softer and also avoids the issues of the implants turning around, which can be a problem with anatomical implants if they swivel in their pocket.
Okay.
The second thing to think about is the fill of the implant, and most of the implants that we use in the UK in Europe tend to be filled with silicone. This gives a very, very nice feel, and even if the implant ruptures, the current silicone implants, which are what we call gummy bear or cohesive gels, the silicone will not leak. So some of the issues that were there with the non-cohesive silicone implants are now overcome by the new implants. And as I said, we tend to prefer silicone fill rather than saline, which is salt water, which is what they use mainly in North America, in the UK. And then the last thing to think about is about the texturing of the implant. And the implants come in either a smooth or a textured surface. And depending on the activity of the patient and the level of activity that they have, I would advise them as to which of those implants is better Textured implants tend to have a Velcro effect, so they stick to the surrounding area, and so they tend to do better in ladies who are very active. Smooth implants don't have that Velcro effect, and they suffer from an issue of displacement, and so they may be more suitable in ladies who don't do a lot of exercise. So there's lots to consider when a patient comes to see me about a breast augmentation, and we talk through all the issues about the type of implants that we're going to use, and make essentially a bespoke plan for that patient once we have a discussion and know about their lifestyle and what they're trying to achieve.
That's great. Okay, so I've also heard about patients having implants put under the muscle and over the muscle. Could you just tell me what is the deciding factor with that? And also, when you're doing the procedure, where is the incision? Is it? I've heard that you can have incision underneath or around the nipple to put the implant in, or is that just down to different surgeons?
Good. But look, let's talk about the incision first, because I think that's the first, really, the start of the operation of how we will commence the operation. There are actually a number of incisions available for breast augmentation. The commonest one is inframammary, or just underneath the breast. The second is a periareolar, which is around the bottom half of the nipple. And the third one is a transaxillary, or in the armpit incision. Now, the inframammary incision is the most commonly used access for the implant, because it allows all types of augmentation to be carried out. The scar generally tends to be very, very good because it's hidden by the breast that overhangs the scar. And so really most of the patients that I have an inframammary incision. The periareolar incision became very popular for a little while, but the problem with that is if the patients get a problematic scar, the scar is very, very visible because it's around the nipple. And so in general, I tend to avoid that now and tend to put the inframammary incision. Lastly, there is that armpit incision that can be used. But the issue about that is that most of the studies have shown that actually implant infection rates are a lot higher for armpit incisions, and you require a little telescope essentially to make a pocket. And so again, the inframammary, or underneath the breast, is the preferred access, and that can be reused again should the patient require a revision or change of implant down the line. And that's the other advantage about it. Right. The second point you raised was talking about the plane of the implant, i.e. either in front or behind the muscle. And for some surgeons, they tend to prefer one over the other. But in my practice, we have a slightly different ethos, and we use the plane according to the patient's body habitus and what they're trying to achieve in terms of look. The underneath the muscle tends to achieve a very, very natural result. And it's for most patients who don't want other people to know that they've had a breast augmentation, particularly if they're very, very thin over the upper part of the breast where the implant can potentially be visible. So the underneath the muscle allows us to hide the top of the implant and gives a very natural result in clothing, so patient or people don't know that patients have had an augmentation done. The above the muscle is actually the preferred method, but again, depending on what the patient is trying to achieve, again, we'll come up to a plan as to whether we feel it's better to put it below the muscle, what's called a dual plane, or above the muscle, which is bizarrely called a subglandular plane. So again, that decision is made with the patients once I know what look they're after and once we've examined them to see what their body habitus is like.
That's great. Yeah, can you tell me how you help a patient decide what size to go for? How will they know what their end result is going to be like?
So this is, again, a really, really interesting and common question for patients come to see me in terms of how we decide an implant. So I examine the patients carefully, preoperatively, when they come to see me for the first consultation, and we measure a number of factors, including the chest width, including the thickness of the actual skin envelope. And based on those factors, I then usually allow the patients to have a range of implants that they can actually have for their augmentation. We actually have those implants in our practice, and what I get to do is to get the patients to try the implants in a bra, so they will see exactly how the implant will look once it's inserted. And with that method of actually trying on the implant that we're going to place into the patient, we find that actually our satisfaction rate is very high. And, we've never actually had to go back and revise the implant because the patients felt it was too big or too small. And so that method allows us to accurately assess for the patient in terms of what implant they want to have post-operatively.
That's great. That's great. So, yeah, also, can you tell me what are the most common side effects that you would see in patients, and, any kind of risk that's associated with this type of surgery?
Side effects are very, very rare for breast augmentation in my practice. I do almost all of our cases under general anesthetic as a day case without a requirement for any drains. I have a special wound closure technique where patients will be able to shower immediately after their surgery. And so actually the recovery is very, very quick. But the issues or concerns about breast implants would be, and the major one is of the risk of an implant infection. I'm pleased to say that actually in 10 years of practice, we've never had an implant infection. So those rates are, again, very, very low. Seroma is a fluid that accumulates around an implant, and that's probably the commonest thing that happens after an augmentation and leads to swelling acutely after the procedure, but generally tends to settle down about 2 weeks after surgery. Patients can be a little bit sore, and those having the implant in a dual plane or behind the muscle tend to be sore for 2 weeks, versus patients who have it above the muscle that are usually sore for just about 1 week. And very, very, very occasionally there may be some bruising. And that's pretty much kind of about it. And as I said, it's an operation that's done as a day case. It's very, very well tolerated with very few complications in our practice.
Right. Okay, that's great. So, before I was under the impression that that you'd have to have implants changed every 10 years, but I've since learned that's probably not the case. How long would you expect the implants to last?
So that's an important question, which no one can really answer for sure. But I always say to patients that the implants are a bit like a car, that actually they're coming off the same sort of manufacturer, but in terms of how they do and how long they last is very, very variable. The factors that influence how long an implant will last depends on the size that the patient goes for, depends on the skin envelope and the quality of the parenchyma over the top of the implant, the level of activity, and also the manufacturer of the implant, because we know that some of the implants tend to last longer than others. But in general, if you look at most of the studies looking at implant surgery and rates for revision, about 10% of patients require revision at 10 years. And
Okay.
one of the problems with third generation implants, which was before the current set of implants, was that rupture was a problem in the sense that the shell of the implant would rupture. And so patients would require a replacement because the shell of the implant had ruptured. The current fourth generation implants, rupture rates are extremely, extremely low. And so we don't yet have 15-year data on the fourth generation implants, but we would expect the rates to be much lower than the last set. And so we would expect the need for implant replacement to reduce significantly. Lastly, the other thing to think about is capsular contracture rate, which is essentially the scarring around the implant that tends to occur, was one of the other reasons why patients required revision. But again, when I started with my practice, 15 years ago compared to now, our capsular contracture rates are vanishingly low, and it's very rare we get capsular contracture. So again, the need for implant replacement is significantly reduced. And what I say to my patients is that unless they are causing you any problems in terms of pain, capsular contracture, or change in shape, which would be indicative of an implant rupture, then you really don't need an implant replacement at a certain time point.
Right, that's good. Last question for you then. Just give me like a brief overview of what the aftercare would be like in your practice. And do you provide garments for the patients to wear home, or do the patients need to buy those themselves?
So in our practice, as I said, almost all of our cases are done under general anesthetic as a day case. There's no tubes or drains to remove afterwards, and most patients can shower straight away because of the wound closure technique that I've developed. What generally tends to happen, patients then come and see me normally 2 weeks after the surgery, where we remove the dressings, and again, almost all patients are healed at that point. Patients then stay in their sports bra for a further 4 weeks, and I see them again as they're coming out of the bra, i.e. at the 6 weeks post-surgery point. We generally then tend to see them at 3 to 4 months following their surgery, and then a further review of 1 year. And if everything's stable at that point, we generally discharge the patients from the clinic and ask them to come back if there's any concerns. With regard to the garment, I generally tend to like garments or post-operative bras. They tend to control swelling. They allow the implant to actually sit in place and take the correct position post-operatively. And we have a number of manufacturers that we use for our post-operative bras. We generally tend to direct our patients to those manufacturers, so they purchase the bra and bring them with them on the day.
Brilliant.
Lovely. Thank you so much. Really, really lovely to chat to you.
Brilliant. Thanks so much. Bye.
Bye, Farron.